Karibu and welcome to this presentation on musculoskeletal conditions that were seen in Magu district, Tanzania, presented by myself, Dr. Giancarlo Carpino. This talk was originally presented to clinical officers and community health worker students on November 15th, 2024. This presentation, I will speak in English. I will try to use simpler English words, and I will speak slower than we would usually. In today's presentation, I will briefly introduce myself. I will talk about the clinic statistics that I collected over working 1 month in Magu district and at Kenyama. And we will use this information to talk about the important musculoskeletal conditions in Northwest Tanzania, which you as healthcare workers will be seeing. We will talk about what the important diagnoses are. We will talk about the diagnoses themselves, and I will introduce you to how to rehabilitate these diagnoses as part of your care plan. I hope that in this presentation, in addition to what is written on the slides, I can talk a little bit more about these conditions and give you more insight into treating them. At the end of the presentation, I have my contact information in case you want to email me. So, again, my name is Dr. Giancarlo Carpino. Here's a photo of me on the slide. I'm a chiropractor, and I was trained in Canada. Chiropractors are doctors and experts of the musculoskeletal system. I have been in clinical practice since 2020, mostly working for myself in Canada. I have been working in Tanzania from September 28th to December 10th, 2024. And I have been working with the NGO Global Peace Network. I have been working at the Magu District Hospital and at the Kenyama Dispensary. Here are some statistics of the kinds of musculoskeletal patients I have been seeing at the clinics. These statistics are from October 8th through November 7th, 2024. So 1 month of data. During this month, I saw 94 patient appointments, and this was working only 3 days per week. I saw 53 new patient assessments and 41 more appointments that these patients came back for follow-up appointments. 30 of my patients were male or men or wanaume. 64 of my patients were female or women or wanamke. Clearly, you can see that there is a need for musculoskeletal care in Northwest Tanzania. This chart shows the age range of the patients I've seen. I've seen many children under 5 years old. I've seen a few children and teenagers. And most of the people who seek care for musculoskeletal conditions are 30 years or older. These are the same demographics or the same age ranges that we usually see in Canada as well. This chart shows the different diagnoses or the different conditions that I have diagnosed during this 1 month. I've seen 29 different diagnoses. Some were more common than others, and many people had more than one diagnosis at the same time. Although I'm recording this a few weeks after collecting this data, I've seen mostly just more of the same diagnoses. Let's look at this chart together. I have highlighted the diagnoses that were most common. You can see on the left, I have seen many children with cerebral palsy, and the two tallest bars on this graph are mechanical back pains and osteoarthritis in the hips and in the knees. The bar that I highlighted in blue are people that have both osteoarthritis of the knees and mechanical back pains. This shows that half of the people who had osteoarthritis in the knees also had pain in the back. Also, I saw a number of people with bony deformities, usually as a result of a car accident or a surgery that did not go well, or a broken bone that did not heal well. I also saw lots of older people with lumbar stenoses, and I saw a number of people with thoracic outlet syndrome and pain in the muscles of the shoulder. These are the diagnoses we will talk about today. The diagnoses with the red star beside them are some of the more common diagnoses I have seen and you will see working in Tanzania. The other diagnoses are conditions I have seen that I think are important for us to talk about and you to learn about. Now we will begin our talk. For these diagnoses, we will only talk about rehabilitation treatment for them. If you have other clinical skills, like prescribing medicine or other treatments, please continue to do those and consider adding rehabilitation to the treatment you can already provide. Rehabilitation means doing some treatment in your clinic, but mostly giving our patients exercises to do at home. The first diagnosis we will talk about is osteoarthritis. This diagnosis is most common in the knee joints and in the hip joints, although it can happen to any joint in the body. As we get much older, it's also common to have osteoarthritis in the finger joints. Osteoarthritis describes a change in the joint where the bones change and grow, the cartilage in the joint wears away and is less. There is less joint space if we took an X-ray, and the function of the joint is affected. Usually it hurts to move the joint feels slow, or the joint feels crackly or creaking or stiff. Sometimes the joint can swell up and feel hot, and sometimes patients will feel numbness or tingling around or below the joint. However, most people have age-related changes in their joints when we look at them on an X-ray if you're above the age of 40. But not everyone who has changes in their joints feels pain. This is why we have to do an assessment to determine if someone's pain is coming from the joint, from osteoarthritis, or just from another reason like a sore muscle. Patients have to meet the specific criteria for osteoarthritis-related pain. Here are the diagnostic criteria that are needed to diagnose osteoarthritis. These criteria are used by doctors all around the world. The box on the left shows the criteria for osteoarthritis in the knee. The box on the right are the diagnostic criteria for osteoarthritis in the hip. If we look at the criteria for the knee, we see that our patients must have recurring knee pain in the last month, as well as if they take an X-ray, we will see narrowed joint space, subchondral cyst formation, these are bony changes, other bony changes like thickening and growth of bones. Now, if we look at some of the other criteria, like if they are over the age of 40, they have stiffness in the morning or after they sit for a long time. This stiffness in the joint goes away after moving for 30 minutes. And there's that creaking or cracking, which we call crepitus, moving the joint. These are what we use to describe osteoarthritis. For the hip joint, they will have similar stiffness and pain in the joint and other bony changes as well. If our patient does not meet these criteria, their pain in the joint is from a different cause or different diagnosis. Osteoarthritis is one of those conditions that people will have for the rest of their life. We can do certain treatments to reduce the pain, but the pain will likely remain. One of the treatment options we can do is rehabilitation. By doing this, we strengthen the muscles of the thighs, the muscles of the buttock and abdomen, basically all the muscles that affect the hips and the knees. For this rehabilitation, we use simple exercises. They are not very hard. We have our patients exercise 2 or 3 days per week, focusing on quality of movement and trying to move their joints normally. In this way, it's like we are training the brain as well as the body to feel less pain. When giving exercises for osteoarthritis in the hips and knees, it's okay if our patients feel a little bit of pain as long as it does not feel too much for them. And as long as the pain that they feel after exercising returns back to normal within 1 day or 24 hours. It is important to let our patients know this so that they are not afraid of exercising. These exercises or rehabilitation program usually decrease the pain and increase the function of the joint, so our patients can move better and feel less pain, although everyone has different results. In my experience, rehabilitating people with hip and knee osteoarthritis, I have seen people do a little bit of exercise and their pain goes away 100%. Other people found very little change in their pain, but they found that they could move better and were more comfortable doing their daily activities and chores. Everyone will be different. You can add to your rehabilitation plan with other treatments that you can do. For example, patients might wonder if they can use a painkiller cream to put on their skin on the joint, and that is okay. Other treatments that you can do to decrease the pain in order to help them exercise are good choices too. These are currently the best exercises doctors are using for rehabilitation of hip and knee osteoarthritis. You can search them and see what they look like and how to do them. These exercises are broken down into 4 kinds. There are exercises for core stability and posture, for strength of the legs, for exercises that are like the things we do every day or our functional activities. And there are exercises that make sure the joints are moving the way that they need to. Do these exercises for 10 times, do them for 2 or 3 sets, and have your patients do these 2 or 3 times per week. If it's your patient's first time exercising like this, they might need to start with less repetitions and only do 2 sets before they do more repetitions and sets. That is okay. The next diagnosis we will talk about is cerebral palsy. Cerebral palsy is very common in Tanzania compared to other countries. We do not know why this is the case. Cerebral palsy, or CP, is a grouping of neurological disorders. These disorders happen due to poor blood flow to the brain of a baby, either during childbirth or during pregnancy. This is similar to a stroke in an adult, where not enough oxygen gets to the brain and part of the brain possibly dies. Depending on the part of the brain that is affected, this can affect the baby's ability to move or balance or talk. People with cerebral palsy have this condition for their entire life. Every person with cerebral palsy has different symptoms and a different amount of effect of those symptoms. People with cerebral palsy grow up, so you will often meet adults who live with cerebral palsy too. There are 3 different kinds of cerebral palsy, or 3 different ways that cerebral palsy presents itself. The first way is spastic. This is when the person presents with stiff muscles, awkward movements, and trouble moving an arm or a leg or their muscles that make their voice. The second kind is dyskinetic cerebral palsy. These people have slow, uncontrollable movements. You will often see them shaking their hands, quickly extending or flexing their knees or elbows, and they tend to be shaky and not have good control. The third kind of cerebral palsy is ataxic cerebral palsy. This is where people have poor balance or bad depth perception. They often walk with a wide stance, like they had drank too much alcohol and have trouble standing up. A fourth type of cerebral palsy is when patients have a combination of any of these kinds of cerebral palsy. When patients have a mixed cerebral palsy, this is associated with worse symptoms, worse outcomes, and lower intellectual abilities. Usually, parents will first see signs of cerebral palsy or slow development in their children around 3 or 4 months of age, where the child is not moving like other children. Now, since every child follows a similar pattern of development, but there is some variety in this, if a child is younger than 6 months old and are showing slow development, this might just be a slow development in a normal baby. We can call this central development disorder. However, we need to begin rehabilitation right away to help that child grow and develop. If a child is showing signs of slow development and stiff muscles, slow uncontrollable movements, or poor balance and depth perception, and they are older than 1 year old, this is when we can diagnose cerebral palsy. Rehabilitation for people with cerebral palsy is fun and challenging because every patient is different. With your assessment of their musculoskeletal and neurological system, you can find out what they cannot do and then help them do exercises for what they need in order to keep developing. For example, if a baby cannot roll, you can show them how to roll to help them practice using those muscles. If they cannot crawl or cannot sit or cannot walk, we help them do that. But more importantly, we help the parent know how to do that. All patients benefit from rehabilitation, but they have different amounts of improvement. This depends on the severity of the cerebral palsy. Some cerebral palsy patients can live fairly normal life just with a small disability if they get good rehabilitation, but other patients will not be independent or not be able to move well for their entire life. All patients benefit from rehabilitation by improving their life though, to help them become more independent and more capable. Rehabilitation for cerebral palsy also helps the family. If the parents, the mama and the baba, do not know what is happening with their child, by giving them exercises to do and helping them understand cerebral palsy, we can help them help their child have a better life. And this takes less stress off of the family by helping the child as well. Global Peace Network, the NGO that I am working with here in Tanzania, has developed this booklet on cerebral palsy. It helps you understand cerebral palsy, and you can also let the parents of the child read this book. It helps them understand cerebral palsy and what to do about it. This book is available online, and it's also printed out to be read and used at Magu District Hospital. The next diagnosis we will talk about are mechanical back pains. This is a big topic, and I could easily talk for 1 hour just on mechanical back pains. Think of this as an introduction to the topic, but will give you enough information to treat patients with this diagnosis. Mechanical back pains are when someone has pain in their spine and it comes from the muscles, the joints, and the ligaments. It does not come from the discs of the spine, the nerves of the spine, or other causes. People with this kind of pain can have pain that came on recently. So we call this acute pain if it is less than 3 or 6 weeks old. And people with this pain can have chronic pain. This means pain that has been around for a long time, more than 3 months. The way that our brain interprets pain is different after 3 months. So the way that we might treat acute back pain versus chronic back pain can be different. Back pain is very common. Most people will have back pain at some point in their life. We use this diagnosis when our assessment shows tight pain muscles and joints and ligaments, but also when our assessment does not show a different, more specific diagnosis, like disc pain or nerve pain. Mechanical back pain can hurt just in one spot of the back, or it can spread out or radiate out. The pain might just be in the back on one side, or it can go to both sides of the back. The pain might be in the back, but it refers into the buttock area or the hip area. The pain can also refer down the back or the front of the leg. This kind of pain will not cross the knee joint though. It's our job to do our physical assessment, to check the cause of the pain, and to rule out other more serious causes of pain. Here are some orthopedic tests that you can search and look up in order to check for mechanical back pain. On this picture on the right, you can see a person with different pain referral patterns. This is even though the pain is coming from a muscle or joint or ligament in the back, they might feel pain in their leg or buttock. Rehabilitation is known to be one of the most important ways to treat mechanical back pains. This information is from a clinical guideline that doctors all around the world use in order to treat back pain. You can see that there are very important things to do to treat back pain, and there are optional things to do to treat back pain that you can choose if you are taking care of your patient. I have highlighted in yellow that you can see that rehabilitation has very good evidence for treating back pain. Here are some rehabilitation stretches and exercises that you can use to help your patients with back pain. You can show these stretches and exercises to them at the clinic. You can practice them at the clinic, and you should also have them do these stretches and exercises most days at their home. This is because if someone sees you at the clinic for one appointment once a week, the remainder or the rest of the week they are by themselves. If we can teach patients to take care of themselves at their house, this means they depend less on the doctor. These stretches and exercises are patient handouts that are on my website that you can download for free. They are either in English or in Swahili, depending on what you think is best for your patients. They are also printed and available to show your patients at the Magu District Hospital. You can also use treatment with your hands to help our patients move better, feel less pain, and just get better faster. Whatever hands-on or manual therapy treatment techniques you know how to do are helpful. You can use massage techniques, joint mobilization techniques if you have been shown how to do those, and other medical treatments that you know how to do. The next diagnosis we will talk about is called thoracic outlet syndrome. There are two kinds of thoracic outlet syndrome, and we will talk today about the kind that is caused from the nerves or neurogenic. This condition occurs when the nerves that go from the neck down into the arm are compressed and are irritated and are sending the pain signal. patients will feel changes in their arm of the affected nerve. They might feel numbness or tingling, or they might feel less muscle strength in their arm on one side or on both sides. This nerve issue is caused from tight muscles in the thoracic outlet area. This is the side of the neck and top of the shoulder area. It's common in people who work with their arms raised over their heads. Think about nurses who lift patients in and out of beds, craftsmen or fundi who work with hammers and other tools all day. And as a result, these muscles of the thoracic outlet area get very tight, and over time they do not relax back down to normal. To diagnose thoracic outlet syndrome, we first take our clinical history, like we do with all conditions, and then in our physical examination, we test or challenge the tissues which might compress these nerves in the thoracic outlet area. Check the scalene muscles on the side of the neck. Check the pectoralis minor on the front of the shoulder. And there are other tissues underneath the collarbone or clavicle which can cause pain as well. Valuable orthopedic tests for diagnosing this condition are here for you to look up. There is the elevated arms stress test, or the EAST test, which is the most important. And these other tests are valuable to be more specific in finding the cause of the pain. Addison's test, Wright's test, and Eden's test. These tests tell us that the patient has thoracic outlet syndrome, and then it's your job as the doctor to determine if the thoracic outlet syndrome is caused from compression of the nerve, which we call neurogenic, or if it's from compression of the blood vessels, the artery or the vein of this area. That kind of thoracic outlet syndrome is called vascular thoracic outlet syndrome. Once we have found the cause of the thoracic outlet syndrome, we stretch the muscles that are tight and compressing the nerves. The most common muscles are the anterior and middle scalene muscles and the pectoralis minor. Use your hands-on manual therapy treatment techniques at the clinic, like massaging the muscles, and do stretches at the clinic to help these muscles loosen. Teach them to do some stretches at home and have them do these stretches in the morning, in the afternoon, and at night. Make sure to hold stretches for 25 seconds at least. This gives the brain enough time to let the muscles relax and stop holding so tight onto the muscles. We need to repeat these muscle stretches a lot, so 3 to 5 times in a row. This is because we want the brain to get out of the pattern of holding onto them tight. We want to train the brain to realize that it can let the muscles relax. Next, we will talk about stenosis of the lumbar spine. This can be lateral stenosis or central stenosis. Stenosis describes when the hole or the space that the nerve runs through becomes smaller. These changes in the size of the holes happen with age, when bony growth happens, or if the space in between the backbones becomes smaller, and the hole that the nerve comes out of can become smaller. This can cause pain in the nerve root, leaving that hole. For lateral stenosis, the holes on the side of the spine where the nerve comes down are affected. And for central stenosis, the spinal canal, or the canal where the spinal cord lives, is stenosed or becomes smaller. For these conditions, they can present very similar with a few key differences. Patients often feel pain in their back and pain in their legs that can come and go or be constant. With central stenosis, the pain in the legs that comes and goes is usually due to blood flow issues in the spinal canal. If there is less space in the spinal canal during certain positions and movements, the nerves will not get enough oxygen and will send the pain signal until we go to a position where blood flow is restored. When diagnosing these conditions, the clinical history is the most important, but we should also use X-rays to confirm the bony changes in the spine. This helps us know if there are bony changes and if they correlate or if they are in the location of the nerve that makes sense for their symptoms. These conditions are almost only in people who are older, 50 or 60 years or older. People with these conditions often have a position that's comfortable and is uncomfortable. For example, with central stenosis, usually sitting or bending forwards with the spine flexed relieves the pain by creating more space in the spinal canal. But when they extend the spine by sitting tall or walking for too long, this creates less space in the spinal canal, so there is less blood flow to the nerves and their pain can come on. Usually it takes a few minutes for the symptoms to come on. For lateral stenosis, this condition is less affected by certain positions, so there may or may not be a position of comfort. Use your normal low back orthopedic tests as well as other parts of a assessment, which we have talked about before, to rule out other more serious causes of pain. And then you can diagnose this condition similarly in a way that you would diagnose mechanical back pain. This condition can be rehabilitated using similar techniques to other kinds of back pain. We can stretch the muscles, we can strengthen the muscles, and keep them moving and feeling well. Even though the pain is coming from the nerves and changes to the bone shape, by stretching muscles, we can decompress the spine so those nerves have less tension or pressure on them. By strengthening the muscles, we can improve blood flow to them, and we can play a trick on our brain. By our muscles being stronger and giving people confidence that they can move, it's like we tell our brain that, hey, I can move, I am safe, I do not need to send the pain signal. Treatment in the clinic is nice, but it's more important to give these patients exercises to do by themselves at their house. This is, of course, because it helps relax the pain generators of the condition, but also so that they feel in control of their condition and do not lose hope. People with central and lateral stenoses usually have these conditions for the rest of their life, unless they get a surgery to remove the bony pieces. So we want to teach them how to manage their symptoms so that the symptoms do not bother them and they can continue to do all of their activities of daily living and that they enjoy. When giving rehabilitation exercises, you can use similar ones to what we have already seen, but also choose stretches and exercises that they can do in a comfortable position. For example, if they feel less pain when they are flexed forward, give them stretches or exercises that they can do in a flexed forward position so that their pain is not aggravated by their rehabilitation. Great job so far. We have been talking together for around 40 minutes. We have 6 more diagnoses to talk about, so this might be a good time for you to stand up, get a cup of tea or water, and get ready to learn about just 6 more diagnoses. Let's continue now. We are going to begin talking about conditions that might be less common but are very important for rehabilitation in northwest Tanzania. The first one is stroke or post-stroke. These are for people who have survived a stroke. Like cerebral palsy we talked about earlier, strokes are caused from blood flow issues to the brain in adults. There are different kinds of strokes. An ischemic stroke is when a blockage happens in the brain and not enough blood flow and oxygen goes to part of the brain. Other kinds of stroke include a tear in a blood vessel in the neck, causing loss of blood, or a thrombus to form, or a blockage to form, which blocks blood flow to the brain. There can be breakage of the blood vessels in the brain or aneurysms as well. Depending where the blood flow issue occurs in the brain, this will determine the symptoms of the stroke, whether it affects their muscles or their sensation or both. For those who survive strokes, by 2 years after the stroke, they are usually feeling much better. We can expect them to be 50% to 90% improved on their symptoms. However, they usually do not return to 100% of their past function. These people can really benefit from rehabilitation, and doing so, we can get them back to their normal life, we can get them back to work, and we can get them back to being able to support their families. By the time you are considering rehabilitation for a patient who had a stroke, they have already gone to the hospital, they have survived their stroke, and now you will assess them for their symptoms. Perform an examination of their musculoskeletal system and a neurological system of their body. Find whatever their issue is and help them train that to get it back to normal. For example, if they have trouble walking, help them walk more. If they have trouble talking, help them practice making the sounds of talking again. They might have issues on one side of their body, or both sides of their body, or just a specific part of their body. Everyone is a little bit different. If you find tight muscles that are causing them pain, or tight muscles that are causing them to walk differently or not be able to move their arm, you can relax those muscles with your manual therapy treatment techniques like stretching or massaging the muscles, or you can use other medical treatments that you know as well. You can consider offering them assistive devices while they do rehabilitation. For example, giving them a walker to help them stand, or giving them a cane to help them with their walking or gait training. If somebody has a drop foot or a floppy ankle that changes how they walk, you can give them a brace or an orthotic that holds their ankle up so that they can walk normally. You can do this yourself, or you can refer your patient to a prosthetist and orthotist here in Tanzania for this. Giving them exercises will be very important to help them keep their muscles loose and strengthen their muscles. When we have an issue of the brain can learn to walk and feel and move again, and it can create new connections to do this. By having lots of practice and lots of repetitions, we are able to help the brain find new ways to walk and talk and move, even if the part of the brain that had a stroke is not working anymore. This is called neuroplasticity. Another important thing to remember is that people who have had big life-changing events like a stroke or a heart attack will develop a low mood or depression. This is not because they are not working hard. It's not because they are not in control. This is a normal chemical change in the brain that happens when we are recovering from strokes or brain injuries or heart attacks. We can expect people to be depressed or have a low mood during their rehabilitation. How can you help people with a low mood or depression? There are lots of ways, and choose whatever is best for your patient. Be kind to them and encourage them. By giving them exercises, you help them feel more in control of their diagnosis or life situation. You might want to consider referring them to a mental health professional who can give them support and give them strategies to stay inspired to do their rehabilitation. Similar to strokes, another condition of the brain that we can do rehabilitation for is epilepsy. Epilepsy is another condition that is much more common in Tanzania than other parts of the world. We do not know why this is the case. Epilepsy happens when the cells in our brain, which are called neurons, they activate faster than they normally should. Neurons send electricity or electrical impulses to talk with each other. If these impulses are too fast and uncontrolled, the brain does not understand what is happening, and this can cause uncontrolled movements. We call these seizures. Seizures can affect speaking and understanding, or they can affect the muscles of our body. Sometimes people will have a seizure, they will fall to the ground and shake uncontrollably, and this can cause injuries of their muscles, bones, and joints. People with epilepsy need to be managed by a doctor who can give them medicine. Rehabilitation cannot fix or prevent the seizures, but it can help the injuries caused by the seizures. Some studies even show that rehabilitation can decrease the intensity of the seizures. If somebody with epilepsy wants to do rehabilitation, perform your physical exam of their musculoskeletal system and their neurological system and help them however they need. Similar to a stroke survivor, they might have tight muscles or have to retrain patterns in their brain in order to talk or walk or move. They typically benefit from manual therapies like massaging or stretching muscles, and they tend to really benefit from balance exercises. Help them realize when a seizure is coming so that they can find a safe place to have the seizure. For example, lying on the ground with no hard furniture around them. Make sure that they talk with their doctor about rehabilitation and knowing the right medicines to take as well. Manual therapies can loosen tight muscles and reduce pain in muscles and joints that have occurred from the seizures. People will respond differently to rehabilitation. Some people will respond better than others, but when we search for the effectiveness of rehabilitation for seizures and epilepsy, we can find studies similar to this one on the screen. This study did a review of other studies that measured effectiveness of rehabilitation for epilepsy. It's like a study of other studies. You can see what I've highlighted, that these doctors show how exercise is a feasible therapy for people with epilepsy. Their symptoms are less and their quality of life is much improved. This evidence shows that exercise does not consistently reduce the frequency of the seizures for people who have intense epilepsy, but this is on the large scale. On the individual scale, many patients do report having less intense seizures and less common, but every patient is different, and we should give patients the opportunity to have more control of their diagnosis by giving them rehabilitation. This next diagnosis we are going to talk about is seen less common in Tanzania and other parts of the world, but it is an important diagnosis to talk about and understand. It is called Complex Regional Pain Syndrome, or CRPS. This condition usually occurs after a traumatic event. Think of a broken bone or a surgery that went poorly. This is when the nervous system is not working properly to a part of the body. This results in pain and other issues that we can see on this image. People who present for rehabilitation with CRPS will have intense pain in an area. It might feel burning or tingling or numb, and you will see other nerve type changes, like changes to their skin color or texture. The temperature might be hot or cold. They may have intense swelling of the area that is affected. They may have decreased function of the muscles or the joints affected by those nerves, and you may see changes in their hair growth or nail growth of that area. This is an example of CRPS in Tanzania. This patient was nice enough to let me take a picture of his CRPS in order to help teach other doctors know what to do for patients like them. This patient was in a car accident and had a broken arm that was stabilized by a surgeon, but it did not go super well. They have pain in their arm and less function of that arm. Let's look at this arm together. We can see muscle wasting from the arm bones being fixed in place with surgery with metal rods or pins, or from joints being fused together. We can see that the skin is different compared to the other hand. There is swelling. The skin looks glossy or bright or shiny. There is less motion in the wrist and in the finger joints. And they complain of intense pain that they are taking painkillers for. Rehabilitation for CRPS is a long process, and it is slightly more complicated. You can start with our usual rehabilitation of stretching the tight muscles and strengthening the muscles that are weak. This helps the muscles and the joints move and feel better. But it's not just the muscles and joints we need to train. We need to train the nervous system, both at the local area and in the brain. Some different ways we can train the nervous system are here. The first one is mirror therapy. This one you should look up or search for. It's a way of using a mirror to trick the brain into thinking the painful limb looks and feels normal. It's like a trick we can play on our brain. There are exposure therapies where we touch or stroke or activate the nerves that are not working correctly and help them remember how to activate correctly in a normal way. Other treatments are available for nerves, for example, using certain medicines or certain herbal or food supplements that can help decrease the pain or normalize the nerve function. Because CRPS tends to take much longer to heal or return back to normal, it's a good idea to work with other doctors and people who can provide treatment. And this way, the patient can try a few different treatments at the same time, see what is working best for them. And this also helps you as the doctor not feel like you are responsible for this patient all by yourself. And it helps you feel better if you have help too. Our next diagnosis is called pelvic girdle pain. It feels similar to mechanical low back pain, but it's more specific. This pain is common during or after a woman is pregnant or has given birth. Due to the hormone changes of pregnancy, where the joints and ligaments become more loose in order to allow for childbirth, women can develop this pelvic girdle pain in their hips or in their low back area or both. The pain is usually on both sides, and some women even have pain at the front of the pelvis or the pubic bone. The muscles, joints, and ligaments feel like they are painful, but it's not because they are too tight like other mechanical back pains. It's because they might feel too loose. To diagnose pelvic girdle pain, we do our clinical history and we do physical examinations that stabilize the low back and pelvis joints, like the sacroiliac joints. This should help relieve the pain. Consider using your usual low back orthopedic tests and add tests that stabilize the joints. For example, the straight leg raise with the modification by Dr. Vleeming. With this version of the test, our patient raises their leg in the air while the doctor compresses or stabilizes the sacroiliac joints, and this will relieve the woman's pain if they have joints that are too loose from pelvic girdle pain. Remember though that pain is a sensation that comes from the brain, not just from the joints or the muscles. Our brain sends the pain signal when it thinks that something is wrong or that we might be in danger. Part of treating any diagnosis is reminding the brain that we are safe and not in harm's way. For rehabilitation of pelvic girdle pain, use similar strategies to other mechanical back pain with an emphasis or focus on stabilizing the muscles and joints. Use our hands-on treatment techniques and other medical treatments you know to help with pain relief. Stretch tight muscles and help joints move if it helps them feel better. However, mobilizing joints only is a temporary pain relief, since we know that we want to stabilize joints, not make them more mobile. Give these patients a good rehabilitation or exercise plan that activates their abdominal muscles, their back muscles, and their gluteal and hip muscles. Here are some good exercises listed on this slide. However, people or women with pelvic girdle pain often will feel this pain throughout their pregnancy and after their pregnancy until their hormones have returned to normal levels. People can sometimes feel pelvic girdle pain for months or years after their pregnancy if they have not sought rehabilitation. You can consider other strategies to give them pain relief during this hormone change process. Many women say that sleeping on their side with a pillow in between their knees or underneath their belly if they are pregnant helps keep their pelvis joints more neutral and less pulled on all night. Our next diagnosis is called plantar fasciitis. This is pain on the bottom of the foot. The bottom of the foot is called the plantar part of the foot. Fascia describes the connective tissue surrounding all of our muscles and bones, joints, and other tissues. It is the tissue that's in between all of the other tissue. And itis means inflammation. So plantar fasciitis means inflammation of the connective tissues on the bottom of the foot. Usually we get this pain from too much strain or too much demand of these tissues on the foot. Think of you using any other muscle, like your bicep muscle. If you want it to become strong, you have to use it and challenge it, but you also have to give it time to rest and adapt and grow. If we never gave that muscle time to rest and adapt and grow, it could become very painful if it does not have time to heal. This is what is happening with plantar fasciitis. It is most common when people go from not being very active, say if they work at a desk all day, to suddenly being very active, like if they are beginning to play sports again. Usually this pain is very intense. People will say the pain feels sharp like a knife or burning like fire, and they cannot put any weight on their foot. They usually feel the pain when walking. It gets worse throughout the day, and it's even painful in the middle of the night or first thing in the morning. This is because at nighttime, our body does all of its healing. It will send local inflammation to an area to heal an injury. However, for plantar fasciitis, the bottom of the foot is already very inflamed. And at nighttime, our body sends more inflammation to the area to help it heal, but this just increases the pain sensation. To diagnose plantar fasciitis, we need to do a full physical examination. Remember that certain pains can come from the back and go down to the bottom of the foot. We need to check if the pain is coming from the tissue at the bottom of the foot, or if the pain is coming from a nerve higher up in the leg or in the back. When we palpate the bottom of the foot in someone who has plantar fasciitis, it will hurt. It usually hurts towards the back part of the foot, or more towards the heel, instead of the pain being more towards the front or ball of the foot. When you feel the skin and fascia and tissue on the bottom of the foot, it might feel like it is crackling or popping under your fingers, like there are bubbles under the skin you are popping, or like you are touching plastic wrap that crinkles. Observe for other changes in the foot that might be causing the increased strain. Maybe it's because they changed their activity, but maybe there are structural reasons causing the pain. For example, if somebody has a low foot arch, a normal foot arch is not too high and not too low, and you can put the tips of your fingers underneath the arch of the foot. But if someone has too low of a foot arch, this makes the foot more mobile. You cannot put your fingers underneath the arch of their foot. This changes the mechanics of the foot so that the plantar fascia takes more strain during walking and does not get as much rest. You can use other treatment techniques, such as a foot orthotic, or referring to a prosthetist and orthotics person, orthotist here in Tanzania for help with this as well. Once you know someone has plantar fasciitis, it's quite easy to rehabilitate. Using our usual strategies of stretching and strengthening the muscles of the foot and the ankle and the calf, we can help the tissues send less pain and heal faster. Hands-on treatments in the clinic are very effective for pain relief, and giving them exercises and stretches which help the tissue on the back of the leg and the bottom of the foot move better are very effective. You can see here on the slide that there is a resource you can use that is printed and available at the Magu District Hospital and is available on my website for you to download and use for free. That shows some great stretches and exercises for plantar fascia pain, as well as having an explanation for the patient on the other page. This is a great way to help people feel in control, and they can expect to get better within a few weeks of rehabilitation. The next diagnosis we will talk about is called discogenic pain. This means pain that is coming from the discs of the spine. Disc type pain can affect the discs of the lumbar spine and cause symptoms in the low back and down the legs. And it can also affect the discs in the neck, which can cause neck pain and symptoms into the arms. This kind of pain happens when the discs are injured. They might have a small tear, or they might have a big bulge of the disc out the back. If there is a big disc bulge, it can press on the nearby nerve root, and similar to lateral spinal stenosis, it can compress and irritate the nerve root, causing pain to go down the leg in the location that that nerve goes to. If there is not a big disc bulge, but there's lots of inflammation at the disc, then all of the inflammation can similarly affect that nerve root and cause it to send the nerve pain signal, and someone can feel pain in their leg and in their back. This kind of pain is very common. It's especially common in young adults who lift heavy weights or work very physical jobs, for bus and truck drivers who sit on bouncy, bumpy roads all day, or desk workers who sit in the same position all day and repeatedly strain the same disc tissue in their back. To diagnose disc type pains, we do our usual assessment of the low back muscles, and it is especially important for us to assess the nerves in the legs. Usually, people will feel pain in their back, and when they flex their spine forward, like they are bending down to tie their shoes, they will feel more pain in the back and often more pain in the leg. If we look at this image, we can see how even though someone might have the cause of the pain in the low back, they can feel a referred pain all the way down their leg. This referred pain can be in the buttock, in the back of the leg, and it can also go all the way down to the bottom of the foot. This makes disc type pain different than mechanical back pain. People with disc type pain might have what we call hard nerve signs or soft nerve signs. This means that they might not have sensation in part of their leg. They might have less control of their muscles. Their reflexes might be increased or decreased. Or they can say that they have these symptoms, but they are normal during your tests. Some special orthopedic tests to consider are listed here. These tests check the pressure and the nerve that goes down the leg. If we do a straight leg raise test and it causes pain, like in the back of the leg, it is likely from a disc type pain or the nerve being pulled on going down the back of the leg. Tests like the Valsalva test or the slump test help us identify if pressure causes pain in the back. People often have disc type pain, and it hurts for them to cough or sneeze with this type of pain. You might even search for common relief positions. People with disc type pain can feel relief by lying on their back with their legs up on a chair, or they might feel relief with lying on their stomachs and pressing their neck and chest up off the ground like a sloppy push-up, or like they are doing a seal pose or seal position. Rehabilitation for disc type pain is a bit more specific than for common mechanical back pain. By giving them the right rehabilitation, by knowing the correct diagnosis, we can help people with disc type pain much better. Of course, we will use similar strategies. We will help the low back move by relaxing the muscles around the back and gluteal region. We can mobilize the back joints because they often get very stiff. People with disc type pain sometimes say, yes, the disc hurts, and yes, my leg hurts, but my tight low back muscles are even more annoying than the leg or disc pain. Only perform mobilization of the low back joints if you have specifically been trained in doing so, and if the person who trained you tells you that you can do them. We should also strengthen the abdominal muscles, because by activating and training these muscles, we take strain off of the disc, and we also help convince our brain that we can move again. For disc type pain, it can be a mild pain that goes away fast, or it can be a very severe pain. For most people with disc type pain, this pain will go away by itself within 3 months. However, if we provide treatment and rehabilitation, then this pain will go away much faster, and they often feel more comfortable while they're waiting to heal. But for some people, if the disc bulge or disc pain is too severe, it can last for a year. Depending on the severity of the nerve effects, they might be a good candidate for back surgery to remove the bulging disc as well. So this is a good chance to work with other back experts. More on rehabilitation. We can specifically give back exercises that help the discs. On this handout that we see on the slide, which again you can download from my website and is available printed at Magu District Hospital, you can give the Mackenzie extension exercises named after Dr. Mackenzie that have been shown to be very helpful for disc type pain. You can also give them a nerve type exercise called a nerve flossing, and this exercise can gently pull the nerve in the leg back and forth to help pump away some of the inflammation and help it move better within our body. The final diagnosis I have for us to talk about today is called torticollis. We call this congenital torticollis when it occurs in very young babies. In this condition, the baby will have their head turned to the side, and maybe there will be a big bulge in their neck muscle. This condition is from the sternocleidomastoid muscle, or SCM muscle, being too tight or too contracted, or is just too short. As a result, the baby will either not be able to turn their head, or they can only hold their head in one direction for most of the time. If their head is constantly turned, this can lead to trouble feeding from the breast. It can cause slower development of movement because they cannot turn their head, and the position sensing nerves in their neck are not learning the best way. You can ask the mama or baba if their baby is presenting like this, or mama or baba might come to you worried about a big bump on the baby's neck. Luckily, rehabilitating torticollis is very easy and very effective. Almost all children with torticollis will recover with rehabilitation. More than 90% of children who begin treatment for torticollis when they are less than 6 months old will fully recover. And for children who have torticollis for around age 1 year old, most of them recover too, though it might be a little bit slower just with rehabilitation. For treating this condition, we just have to treat the tight muscle. We stretch this tight SCM muscle at the clinic. We show the parents how to stretch this tight muscle, and we teach the parents to do this stretch on their baby a few times every day. This helps the brain learn to stretch and grow the muscle. We should also have the mama and the baba hold baby in positions where they have to practice turning their head, and put them in positions where they will practice strengthening their muscles and turning their head. For example, lying on their stomach, lalia dumbo, in order to develop muscles, neck strength muscles. And in this video example that you can check by yourself, it shows a gentle stretch of holding the baby in your arms. That is all of the diagnoses we said we would talk about today. As a review, we talked about 12 different diagnoses, some of which are very common and you will see most days doing rehabilitation. Other diagnoses are less common, but are unique that rehabilitation does a very good job of treating them. By being able to perform rehabilitation, you can very positively affect people's lives. In conclusion, thank you for listening to my talk today. I want to tell you that you are already doing a very good job treating your patients here in Northwest Tanzania. I'm happy that you want to learn more. If you choose to do rehabilitation as part of your clinic work, it is very rewarding. You can give patients immediate benefits that they don't always get with standard medical treatment. Your patients will like you a lot for this. They also learn to trust you because rehabilitation is a very close treatment where you use your hands and they visit you more often to make sure they are getting better. I hope that you consider adding rehabilitation to your treatment in order to help your patients better. And if not, that's okay. Consider referring your patients to somebody who does do rehabilitation, like a physical therapist or physiotherapist. If you have any specific questions on these diagnoses, you can ask your colleagues or search the internet to learn more. But you can also visit my website or send me an email if you have specific questions. I want to give a special thank you to the NGO, Global Peace Network, that organizes doctors like me to come to Northwest Tanzania to help teach. Thank you very much, and I wish you all the best in your practice. Goodbye.